My name is Carrie Jo Braden. Carrie Jo is a first name. I have no middle name. And I always say you can call me Carrie or anything but late for dinner. My role now is I'm senior faculty here in the School of Nursing. However, I came here in 2000 in July to assume the position of Associate Dean for Research. And I was in that position up until September of this year. And I have just stepped out of that position into glorious full-time faculty. I am a clinician first and foremost. Nurses are, it's an applied science. My basic degree is a Bachelor of Science in Nursing. I always say I was born as a scientist through that degree. It's etched on my backbone from the BSN on. You are a scientist. Yes, I'm a clinician. Yes, I'm a scientist, which means the development of my clinical role and my knowledge building role always are integrated, consistent with however I understand how to do each of those. And as I move through my own professional development, of course, I get deeper and deeper into and better, hopefully, at being able to do knowledge building and being able to do clinical work. But you have to remember, I started with that first degree in 1966. And in the times, a Bachelor of Science in Nursing was a pretty big thing, to have that be your first degree. And something I was very prideful of, and felt a deep responsibility to ensure that always I kept that scientist piece going. Now, the 60s, the 70s on, I'm a woman. Your family life gets part of that. I mean, I was out of my basic degree when I was 21, married, Vietnam War years, husband in the service. So typical for our profession, we don't go directly from our undergraduate degree into the advanced degrees. Typically, we work, and particularly in the 60s, I don't know that I even knew there were other possibilities. Worked in my clinical expertise role, which is community health nursing or public health nursing, building strength in that area, doing the scholarship along the way. But I didn't go back for my first master's work until I'm trying to think, it would have been early 70s. In the thinking of, to get a bachelor's degree, as I said, up until that time I had been talked with by everybody giving me advice, go get your diploma. Go be a clinical nurse. And when I found out there was such a thing as being a nurse, but also having education, a degree, a bachelor's degree, well, there was no other thought for me. And it happened, I went to a very excellent, strong liberal arts four-year school in Indiana, DePaul University, which, is sometimes they called it the Harvard of the Midwest. Well, it's not exactly that, but pretty high level, students' performance expectations for graduates. But even then, in the 60s, we were not thinking there was more we should be doing. Wow, you got your bachelor's degree. How great is that? As I grew in the clinician role and the places I worked, I like to have impact. And it was getting clearer to me to have impact, I needed more professional education. In part, I did start teaching up in, I'm trying to think where it was in Minnesota, Rochester, Minnesota. I had a chance to, that's where I started undergraduate program there, small Catholic liberal arts affiliated with Mayo's, and started as an assistant instructor pushing the AV cart around. Well, wasn't long before I figured, no, if I'm really going to help students make impact like I have been trying to make impact, I've got to have the education behind it to be a better teacher and to do better. So I started back to school. The choices were not great. There was not a master's in nursing program close. My husband was getting his undergraduate degree at across the river in Winona. And so I picked up a preclinical master's degree there in psychology. I did that because I didn't want to go back. I couldn't go for an ed psych degree because then I would have had to get another undergraduate degree. Well, that's pretty silly. So I did the clinical psychology, taking all the courses I could take that were ed psych. And so that was my first master's degree. And I thought, well, okay, that's good. And, did my first research in terms of the first thesis, which focused on students and learning anxiety. And, felt pretty good about that. And then again, as you grow and develop and change your jobs, you realize in education in those days, I wanted to always teach in bachelor's programs. I did not want to teach in a diploma program. By then, the AD program had come along. I did not want to teach in an ADN program. I wanted to keep it with what I would say the high-quality basic degree. In 1966, there was a statement that came out that all nurses should be prepared at the bachelor's level. And I thought, okay, good. I did it right. But, that never happened. Never really happened. And I watched that unravel across the years, that expectation for all sorts of reasons. Associate degree, which became very popular. I suppose had that been available when I was looking, somebody would have pushed me that direction. I'm from a family without a lot of money, not a lot of resources. That's the way to go for many people, stepwise. I might have been tempted to do that. I'm just happy it wasn't available. Because, again, I was able to start as a scientist. I knew that always as part of my role as a nurse. Certainly life happens, no matter what your plans are. And although I had great plans for more education, I was able actually to pursue those all the way through the first master's without difficulty. We didn't start our family right away, to the despair of course, our parents who were expecting children right away. But no, we were able not to do that. And then I'm just trying to think. Our son was born when I was teaching at that one of the Catholic little schools along the way, which was fortunate because I didn't get dinged for poor family planning. Which, in some jobs, that's what would happen. You would, sorry, you can't teach here now. And they couldn't say that in this lovely little liberal arts Catholic school. The nuns were very supportive. So our son was born in February, in the middle of a semester, but that was fine. That's kind of the first thing, and then we moved to, my husband's pursuing his education. He's going for his master's, made the move to Wyoming for that, started teaching at the University of Wyoming. Now I'm in a bigger system, and seeing the lay of the land for what's expected of teaching at the university level. And that's when I began to become aware of NIH, of other expectations. So that would have been in the early 70s, before I even was aware of that world. In the scientists, and it really got driven home to me in Wyoming because Wyoming had a number of NIH grants in, and somebody, and that wasn't in the School of Nursing, but somebody in another part of the university did something terribly wrong, and the NIH funds were withdrawn from the university for a period of time. Again, this is adding to my understanding of this is a big thing, but how it impacted me is I was last hired I was on soft money. NIH monies went away. I was out of a job. And so I went back to Indiana University, another big system, and that's where I was strongly encouraged now to start getting a doctorate. I don't know that we are set apart from other research fields. We have the same rigor in our research. The thing is, we are clinicians, and the sources of our research questions generally come from our clinical practice. I always call it clinical wonderment. What is the clinical question that nags you when you go home? You scratch your head and you say, why does that happen? Oh my gosh, it happened again. Why aren't we doing something about it? And that's usually the source of our research. Not unlike other clinical researchers in medicine or dentistry or other things. Quite often that's the clinical wonderment's what drives your program of research. So, and then the only other thing I could say that might be different about our approach to research is our discipline is a holistic discipline in terms of how we view the world. So if you look at philosophy of science perspectives, we don't fall into a positivist stance. We're not necessarily quantitative in all our research. We don't necessarily say the clinical trial is the bee's knees. We view whatever this clinical wonderment is from a whole array of points of view, including, because we deal with people, including the people who are experiencing the phenomenon of interest. We don't cut them out of the research process. It wasn't until much later that I learned you can officially incorporate persons who are experiencing the phenomenon as your co-researchers. I didn't learn how to do that until later. And it probably wasn't part of what I was being taught early on either, because there wasn't a lot of it going on in the places that I was. But that's really what I believe you have to do, just as I believe that for my clinical practice. I'm not the end-all, be-all, know-all for people that I'm working with to provide care. I always say I'm a public health nurse. I work with people. We grassroots. We work with their strengths. It was only much later I learned what I was doing is called health co-production. So a lot of these things I did, believed in, valued, drove my work, didn't have an official name for it because I didn't know it existed, found out about it later. I said, oh, that's what I've been doing, health co-production. But it's the same notion in research. We co-produce knowledge because the phenomena aren't existing just in my eyes, for my needs, to put a line in my portfolio, $1 on my NIH. No, this is about real people and real needs and how to approach it in a way that's going to build knowledge appropriately with them, so it's usable. It has to be applied. So that's another earmark of our work. For the most part, it's applied. It informs intervention. Yes, we do basic research, but it builds to eventually being able to inform intervention. What makes anyone think that being practical doesn't mean you have to have knowledge to support it? Of course you do. Where does that practical stuff come from? The end of my thumb? No. It's got to come from evidence. Again, evidence-based stuff, that language came later. But we always knew you had to have evidence to support your practice. And you had to get that evidence in an appropriate, rigorous way. You had to follow the rules. You had to build it in an appropriate way. I used to get the question, how come you're not an MD? When I was going for my PhD, and how come you're not? I said, because I'm a scholarly doctor. In fact, I even had the internist that I was working with when I was doing the practitioner part of my work, postmasters, who introduced me to a colleague somewhere along the line. He said, she's going to be a scholarly doctor. So I thought, thank you. Well, this is part of balance. And it's difficult, actually. It's more difficult as we go on because the funding resources to support your research are harder to get. Therefore, to do it within a full work week where somebody's paying you to do something not research can be difficult. But again, because of my basic education, my belief and value for what I was bringing to any work setting, I never would work in a place that only expected me to mop the floors. I would never accept a position where I was not hired as a scholarly person that would be building knowledge, contributing to that wherever I was working. I wouldn't take the job. Or if I found that it wasn't in the job capacity, I would leave. I will give you a pretty good example from my very first job. 21 years old, Sault Ste. Marie, Michigan County Hospital. Cold, really cold. And I'm working, they put me into a pediatric unit. I'm trying to think, evening shift, charge, because I was the only one with a bachelor's nurse background, bachelor's degree background. I'm there a week, and the population of kids are kids with croup and upper respiratory stuff, and the care protocols were archaic in terms of what I learned about how you care for children. Parents were not allowed to be with them in the evenings. And of course, feeding comes up in the evenings. There's not enough staff to feed, therefore they prop bottles. And the first set of path reports that came across my desk, I can remember sitting right there at that nurse's station, reading the path report, aspiration, pneumonia, milk. Aspiration, and it was like ding, 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 ding. This kid didn't come in with aspiration, pneumonia, milk. He came in with, you follow the history. This is what happened. How did that happen? We did it. And I started immediately calling parents saying, can you come in this evening to feed your baby? And yes, I tried to clear it up, but I was charge nurse on evening. I thought I had that right, and I took it. Well, I guess I didn't have that right. And I ended up going all the way to the top person in charge of the whole hospital with my story and to say, now I'm willing to work with you to help change this because you are killing babies, and I don't want to be a part of it. And I know how to help fix it. No. He told me I should be very pleased as a bachelor's prepared nurse to have this opportunity to learn to be a clinician. And I said, then you'll be pleased to accept my resignation. I said, I will not work here. And I never worked in a hospital again, full-time. They had to call me in part-time because they needed me, but I was always under the caveat that I get to do what needs to be done to do good clinical work and not to perpetuate things that are going to hurt people. And that really cinched it for me in terms of my career path as a public health nurse, because I had autonomy of practice. So I never put myself in a position where I don't have that. Well, I mean, isn't that who we're serving? Isn't that what the knowledge building's about? Again, it's not about glory. It's about serving the need, and that's part of our social, what do they call it, our social mission, the thing we sign on to, our pledge that we make as we get our first caps and our pins and our social mission. That's our responsibility, is to serve people. Well, it's not unlike a lot of health professionals. We're there to, in my case with community health, is to ensure people stay healthy is do the best I can. Health promotion, primary prevention would be my little piece of the whole pie. Not so much on the other end, but keeping them out of hospitals, keeping them healthy, productive people. I did work as a public health nurse in Indiana after my husband was discharged. And he was coming back to go to school because he didn't have a degree, and we went to Indiana so he could start his bachelor's degree. And I became the first county public health nurse in this rural county in Indiana. And I'm trying to think, in that job, became aware of much more the needs to build a practice that encompassed the 20,000 souls that lived in this county, that they would be part of building all of this. And of course, that's before I went on for more education, but the awareness that that's where the reality of my practice strength would be. Well, the problems the clinical wonderments that came out of that had to do with occupational safety issues on the farms. I had farmers who had amputations with their lack of resources to maintain their health. I mean, a whole host of clinical wonderments, which I didn't pursue at that time. But just this past week, one of the nurses who was rewarded at our national conference as a trendsetter was a nurse in a county not unlike the one I was in those many years ago. She was in Kansas. And she was being rewarded for a very innovative intervention with farmers. Had a farmers' dinner theater, is what she called it, intervention. And it was for the purpose of working with them relative to improving the health of, the farmers in, the rural people in that county. And I sent it to the students that I work with in the theory course to say, see, you can do this kind of work no matter where. You can be a scholarly practitioner no matter where you are doing your practice. And I pulled her vita to look at what she had done and all the publications along the way. Now, had I, back in those days in Indiana in 1969, known all of this stuff, I could have very well stayed there and established, gotten my education as she did. But see, I'm not alone. That's what I'm saying. I'm not alone. There are nurses everywhere, scholarly nurses in practice, paying attention to the clinical wonderments, building their professional development in line with addressing those wonderments, coming up with really great, lovely interventions that work and that they get the evidence for and then spread. So, just to say my path differed from that woman's, but it could have been that woman's had I stayed in that little. It's your mindset. It's your belief in what you're supposed to be doing. It's not, you don't have to go to a big practice, a big city, a big this, a big that, to be a nurse scholar practitioner doing great work. And of course, there's not a lot of diversity in any of those places. Indiana, Wisconsin, Minnesota, grew up in Michigan. So this opportunity to go to Mississippi in the 80s, I thought was an important thing for me to do to begin to get a better feel for a wider population base and to better understand experience of a more diverse population, and then discovered that these strong public health standards that I was used to and resources I was used to in the Midwest and Canada didn't exist everywhere. I didn't know that. I didn't know that you didn't have public health nurses in places like Mississippi. I didn't know the state health department didn't necessarily support health promotion at the county level. I didn't know any of that. And so that was good to learn. Went from there to Arizona. This is family linked. My mother's had a chronic illness. We had our son. It was time to be with family, and time to go for that degree. And so that's where I went to the University of Arizona for the doctorate, and also learned then more about the border area and what that was about. I have a minor in sociology, but the funny thing is that this is in the 80s now. Our nursing education is always so funny, so restrictive in many ways. Jump through this hoop, that hoop, the next one. And I didn't have a master's in nursing. So I had to get a master's in nursing before I could. They knew they wanted me in the PhD, but no, I couldn't go until you get your master's in nursing. And so I took it there at the University of Arizona. And of course, I took it in a Master of Science in Nursing, majoring in public health. The year that before I came, they were using my textbook. The year I was in the program, we did not. Now people say, wait, how did you get a textbook? I'm telling you, if you are a nurse scholar, if you are committed to scholarly work, you write, you disseminate, you develop in those opportunities. That opportunity for that textbook came out of Indiana University. I had a co-author. That's in part why I was recruited to Mississippi, was based on that textbook, community health textbook. I had the second contract for just on my own, the next textbook from Appleton Century Croft, and was working on that when I did my doctorate. So how do you do all that? Well, I didn't take a clinical job. I worked at school as a teaching assistant. We had a 3-series course. The first was a community assessment of some issue, some problem. The second was working with the grassroots group that you work with to plan intervention. The third was to third semester, deliver and evaluate. All right, my clinical wonderment, what was that? My clinical wonderment had to do with chronic illness experience. Where did that come from? This comes important. Yes, from my clinical observations, yes. Seeing people in the community with in the case I was focusing on arthritis-related conditions, being very functional. And my mother's chronic illness was rheumatoid arthritis and the host of disease. And by that time in my maturity, I was ready to deal with it. And so that became my clinical wonderment. That's what I framed that 3-semester course sequence around. I affiliated with the Arthritis Center there at the University of Arizona to do that three-semester work, negotiated with them to contact a group to build intervention. Started with a group of persons with lupus, and we built we did the assessment. We built the intervention, which was a self-help course, and we delivered and evaluated it. Because we built those things as being able to be taken over by the people we're teaching, because there's nothing I do that's magic. And I don't know if you know, in the 80s, what was that magazine? Mother Earth News, which of course I used to get, with my babushka at home and growing my garden, of course. And there was an interview in there with Tom somebody, I can't remember his name now, he was a medical student at Yale. And he was talking the same thing. There's nothing I'm learning here that people can't mostly do for themselves. So there's no real magic here. Why are we making it so mysterious? And so out of that, whatever interventions we have, they're done mutually, they're done, other people can take them over, and that was the pattern there. We started to train the trainers. The next level of teachers were people with lupus or arthritis, chronic disease, whatever. They were in Arizona and Tucson because of the weather. They went back to the north. They took the course with them. They sponsored it there, and it hopscotched across the country from there. I was long out of it as the chair working on my doctorate and got that done. My first year as faculty member at the University of Arizona, I got a call from the Arthritis Foundation in Atlanta saying, "Carrie Jo Braden, are you the person who was the chairperson on the development of the SLUSH course, Systemic Lupus Erythematosus Self-Help?" I said, "Yeah." And they said, "We would like to take that course over to deliver it nationally as part of our product line, or whatever they do. Would you like to be the evaluator?" Well, of course I did. And that was the first outside funded research. I had other funded research from NIH for the student support. I think I had a application under review for what was called a FIRST award, which would support a new faculty person 50% to do research. So that was under review, and this came in. So by the time I was in my second year of faculty, I was funded 70% from outside. It's supposed to be so relevant, so on target. And I know it'll only last for a certain length of time. There's nothing forever. And self-help as a movement has waxed and waned. I can kind of tell by how I'm cited, who's calling me, who needs this, whether it's on the growth or the other, what country is particularly interested in. There was a while there where the Eastern Bloc countries were and I thought, I'm not going there. You guys figure it out. I'm not a risk taker that way. That's about the time the wall was coming down. No, I'm not going to go there and help you do that. But that notion of self-help so far is still pretty out there, and it's on the rise again. My publications are old, but boy, they're getting dinged a lot. So the self-help intervention project was the outgrowth of the lupus one. When I started my doctoral work, then I was fleshing out the theory that underpinned those self-help interventions developed during the master's program, so that they went together. I had the middle range theory that supports it in hand. That's what the dissertation was about. And the research I did was still with arthritis, to test the model and all that. But right after that was done and I was out, a call came from the National Cancer Institute for self-help interventions. See, it's on the rise, it's on the drums. NIH is going to pay somebody to do it. Maybe I could. Well, let me think. What have I learned from my work that could be applicable? Well, for one thing, I'm not an oncology nurse. I knew I would have to expand the team. But I knew that some kinds of cancer were being viewed as chronic illnesses then, and breast cancer was that was just about the time you were hearing about breast cancer as a chronic condition, chronic something. And I thought, okay, well, that's women. Most of the sample I've dealt with in arthritis, lupus, have been women, some men in there. I know the self-help stuff works in that chronic disease. Would it work for management of post-diagnosis cancer, breast cancer? I did look at other cancers first because I knew if I was going to do clinical trial work, you have to have a big enough sample to do it with. Well, what cancers are big enough to do that? I also knew, because my stuff is based on learning, that it has to be a cancer that you don't die from in 6 months. You have to be learning. So, pancreatic, no. Lung cancer at that time, pretty steep trajectory. So breast cancer seemed to fit. The trajectory was, for the most part, more shallow, time for people to learn. It fit with my theory. Okay, could we refine the intervention strategies for that population? We did. We had a fuller team by then. This is where more of the interprofessional stuff comes in. I had nurse oncology. I had a nurse whose background was in clinical psychology to deal with uncertainty management. I had oncology physicians. So the team was bigger, and we built the intervention, put it on protocol, tested it several times, several clinical trials across the country. And the thing that you saw on Ivanhoe News distribution was the first ship for women. So that works out there. That's going on. No one's formally taken those interventions and put them into a foundation and used them. They were posted for a while on the NIH interventions page, but I don't know if they're still there. But they're being used in all sorts of cancers and now other chronic illnesses. So that's another whole evolving, without me, life of its own. Resources nationally became more available to give us the money to do some of this community work, because all of that was done free before. You just did it. It was part of your pilot work. You just didn't have money to support it. And now PCORI was funding things. You could talk about health disparities now. That wasn't out there in the world. Even here, because by then I was here, the fact that we were in Hispanic serving institution wasn't in people's awareness until I was here in 2000, 2002. 2001, I was working on my first Center grant, and then saw that designation as for Hispanic serving institutions, saw the criteria, and said, well, surely we are, and check that out, and we were, because you wanted that to be incorporated in your grants, to give you a step up. So always my work here has been very grounded in that health disparities. It was a P20 center. It was funded out of NINR, that's the Nursing Institute for Research, and their idea was to pair what they called a majority institution, and that didn't mean in terms of demographics, that was majority in terms of strong research base, with a minority institution, again, not demographics, but in terms of research strength, to pull them together into a center so that the things that a majority institution knew how to do to foster research could be transferred into the other university. I was new here as Associate Dean for Research. Certainly seemed like a great thing to go for as an Associate Dean here to support our growth as a research institution. And University of Michigan was our partner. The work on that center grant, we worked on it together, but a good part of our part of it came from that very first center grant that I wrote in 2001 when I found out where I was living and what the border. I didn't know where I was living, really. I didn't know about the border. I didn't know about colonias. I didn't know a whole lot, and I thought, well, I'm not going to say what I thought about where I had landed myself. But in terms of disparities, they were right there in front of me at a level that I hadn't really truly always experienced in other places. Listen to our mission statement for this university now. Very different than it was in 2000 when I came. Did I have anything to do with that? Maybe a tiny little bit. So that's where I'm working at the system level now. When I learned to be a change agent back in the 60s, in that first degree, we were taught how to be subtle change agents because we were Midwest women. I was not out on a line protesting. We learned how to work in the background. I've had people tell me they see me work over time. They figure it out. They say, Carrie, you are water on stone. Drip, drip, drip. And I said, you are exactly right. That's the change tactic I learned. And I learned it well, and I do it all the time. For one thing, when I was at Arizona, getting my doctoral degree, Ada Sue Henshaw was one of our faculty. She became the first director of NINR in Washington. So the growth of nursing research happened during my tenure, and seeing nurses that I knew, that I had worked with, who were my faculty, be leaders of that in the national level. Having the availability of funds from NINR was really a great thing. It still is a great thing. They don't have a lot of money in their budget, but they do good. They do good stuff. I myself don't rely on them for my funding. I'd rather rely on the big guys with the big money, and NCI was my choice. If I had needed money for the arthritis work, I would have gone to those choices. I did, and so the other thing that was happening then in terms of review at the national level for grant applications is they were broadening the people who were at the review table. Okay, so here I am, woman, in a discipline that's not represented well at the table. By then I was getting older, had research, strength behind me. They had an emptiness on their review table. Oh. And so I started getting tapped to go to Washington to review. Certainly as a token, certainly, I don't care. I'm there. And while I'm there, I'll make my mark. And so those review tables opened up immensely during those years, not only with people from other disciplines, not only due to gender, but also, and not only due to age, but also community representatives are now starting to be on these review grants. And then funding agencies popped up like for Corey that actually preferred those kinds of, they really rewarded those kinds of things coming in. CTSAs came up. So, I was able to participate here in the early planning of the CTSA. At the table, Mike Lichtenstein, I really, like how he proceeded. He was heading that planning thing. I wasn't necessarily invited to, I don't even know how I knew they started to meet, but I did know, so I showed up. And gracious. That's one thing about being in Texas. The men are pretty gracious. I can kind of count on that. They don't throw you out by your ear. If I'd been on the East Coast, they might have done that. But he was puzzled. And quite often people would ask me, what are you here? What? But I had to make sure I had something to contribute. And then a lot of us had a lot to contribute to that planning grant. On the CTSA, nursing faculty did step up to that plate. Your students are blessings. Even as I think about the people that who are I don't want to say our patients, who work with us relative to improving health in our whatever world we're working in, people who are experiencing the phenomenon of interest that need some help with it. Just as they have strengths to help us do that, sometimes we forget that students have many strengths that they bring into a learning situation, and they're not deficit people as they enter our programs. They are strong, insightful people, and we need to engage them in the learning processes from the get-go as partners. So, it's hard to do in your own school, and it's harder to do across disciplines, and it's absolutely necessary. So that's our growth potential. And if we don't learn how to do it, I'm going to say, if we don't learn how to do it, we will be extinct. There's one nice thing about being in Rochester and interfacing with Mayos. PBS just had a special on Mayo's recently. It reminded me of that model of care delivery. And I thought, why isn't there more of that? That was really what I was hoping to happen. everywhere. Well, at Mayo's, their faculty, their physicians are on salary. The business model is not to make money. Yeah, I mean, they're not going to go downhill. It's all fed back into serving. They were affiliated with the Catholic school up there. I can't remember which order it was, but that's where it started. This is what you're supposed to do. I had forgotten that the head guy, I can't remember the Mayo, the father, but I think he was Scottish, and I had forgotten that. And Scotland is where the health co-production stuff is really going to town. As I said, in 2002, that was early days me being here, and I was reaching out to the Cancer Center, given that my background had been in cancer research. In fact, the SHIP studies were winding down just before I came, and I had interventions that could have been brought with me. I had potential to collaborate, so I was contacting a whole variety of people. And I think Charles Thomas was also relatively new then, and he had a history of working with nurses as partners in care provision, and so we formed a collaborative relative to building both clinical and research ties between certainly the radiation department and the School of Nursing. Now the thing was, I didn't have any nurse oncology researchers in the School of Nursing, so it was always difficult to get a good cadre of strength together. But as we first started, one of the first things we did was a conference, a whole school conference, which they helped us put on. Paying for the helping to pay. They didn't pay for the whole thing, but the speaker to come in, and they served, I think, as some of the monitors, some of the presenters. So that collaboration went on probably as long as he was here. And then when he went on, there was no one to interface with. It's important because that's where the need is. I mean, the need is for all of us to be together working on this. The need is not for us to be working in isolation from one another. The need is for us to be a team with the people we serve. And that's a new notion in many of the other health professions, too. I always have to remind people, wait, we're missing a team member here. Wait, this person has got something to say. They have strengths. So we're in very early days with our ability to think about that. It's interesting, again, way back in the 60s in Canada when I went there, I was in Sault Ste. Marie. McGill University put in place some kind of interdisciplinary program there. And I don't even know how I got this. I'm a good person at gleaning resources. And I got their curriculum somehow. I had McGill's interdisciplinary across the professions curriculum, and I wasn't teaching, I wasn't in any institution to make use of it, but I carried it around with me for years and years, tattered and torn, and now I have no idea where it is. And I frankly haven't looked to see whatever happened with that program, to see if it ever took off, if they got something out of it, if it's still there. I know we have faculty here, Carol White, who graduated from McGill, and I have never even thought to ask her about that, if it's still going on. But that was in the 60s. I mean, we were thinking that way. We've thought about this a long time. All of us have. All the different professions have.